Hello everyone, this is Shadi Reis from CVI 2024. I'm privileged to be with Dr. Vijay Iyer, Chief of Cardiology at Buffalo University. Dr. Iyer, thanks for having you again.
Thank you, Chadi. Thanks for having me.
Always a pleasure. So, mitral valve, as we know, this is kind of been exploding with devices, but now it's very hard to once to identify the disease, we have too many options on the table. So which device and which therapy is appropriate for patient? I think this is becoming a key and skill set of the interventionalist.
Yeah, mitral valve disease tends to be very complex and no two mitral valve patients are the same. And that is reflected in the spectrum of devices that are being developed or already in development. The reality is that at this point, surgery continues to be the gold standard for treatment of most degenerative mitral regurg for low-risk patients and for some of the patients who have mitral stenosis.
Yeah.
Where we are trying to develop the transcatheter approach are for these quote-unquote non-surgical patients or high-risk patients. Unfortunately, all the trials and all the device development has been very slow due to a number of issues, primarily related to the fact that mitral valve disease is complex, it's very heterogeneous. One device doesn't fit everybody. The edge-to-edge repair for degenerative mitral regurgitation in high-risk patients clearly is a very good option for those patients. Edge-to-edge repair in patients with secondary MR, also a very good repair. And we have devices now like the mitral clip, which has been approved, and the Pascal device, which is also approved for degenerative mitral regurg. There are a number of trials going on now for replacements, but none of those are close to being approved for therapy, and they all have their own issues. The 3M trial, which is the Edwards mitral device, with a ring and a docking ring and a valve, is probably going to be the first device to be approved based upon the trial being completed. But again, it is not going to be for everybody.
Yeah.
So as a consequence, we still have a large number of patients who are very high risk of surgery or prohibitive risk or high risk and still don't have good transcatheter options. So this is a field that is still evolving. We are still trying to learn what's the best way to deal with these patients. And more importantly, mitral valve disease often goes hand in hand with heart failure. So there are obviously a lot of devices being developed for heart failure as well. So where these devices fit in the spectrum is still a work in evolution.
Absolutely. So now from your perspective as Chief of Cardiology and Service Line, usually you want to build a program for mitral valve, right?
Yep.
So not everybody should do mitral valve, especially if they're low volume. So there's definitely a threshold or number of procedures a person should do before they feel comfortable.
I think there are some, so the concept within a service line, the most important thing you can do for your service line is to really have good mitral valve surgeons, because that is critical for you to build everything else around it. Without that, everything else fails. And then subsequent to that, when you start to think about transcatheter mitral valve, you start with the mitral clip program. How many is enough for somebody to do mitral clip? The training requirements are fairly simple. They say you need to have a certain number of transceptor requirements. That's, I think, 25 at the last I checked with Sky and with ACC. And clips, I think if you've done 20 to 25 clips, I prefer 50 in your training, you're probably good enough to get in to start doing the procedures. But once you get in, you have to be able to do at least 20 to 25 a year. Unfortunately, there are not a lot of programs that do that volume, what that means is that most places have volume adequate for only one operator. So you're probably better off. And I think the best way for programs to do that is to have people double scrub this. Mitral clip is one procedure which Medicare allows you to double bill for it, the 60-40 rule, so to speak. So whether your second operator is a surgeon or the second operator is an interventionalist, it certainly is something you can build so that you have two people who are constantly getting exposure to these cases, and that forms the framework to do all the other stuff, the transcatheter mitral valve trials, and eventually some of these will become commercial. But for most people, that mitral hurdle is going to be hard, even for people who are trained structurally. When they come out into the real world, they may be doing more aortic valve and maybe some appendage closures and maybe not a lot of mitrals to start with.
Absolutely. Final thing is the importance of structural heart coordinator or navigator in the system.
Yeah, I think, service lines have to develop these, but more importantly, the heart team concept. And I think within the heart team, whether you have a navigator or a nurse coordinator or a nurse practitioner who's navigating it is extremely important. These patients tend to be complex. They have a lot of needs. they can easily overwhelm your system with the number of patients coming in, the needs of their system. They're in the ER with heart failure. The referring doctors are calling because they don't really have a good understanding of what's going on. So it's important to have those pieces. Otherwise, it leads to a lot of frustration on both sides, for the providers and for the patients, and also for the referring physicians. So whether you build that within the context of a structural heart program or separate it from that within a heart failure program, that's for the service line to decide. But having dedicated resources is critical.
Absolutely. Well, Dr. Iyer, thank you so much for your time and for enlightening us about the mitral space and what's new. To watch this videos and others on CVI YouTube channel, this is Shadi Reis from Denver, Colorado.